joined now by Dr. Judith Feinberg, who is a professor of medicine and infectious disease at the medical school at the University of West Virginia. Judith, it's good to see you. It's nice to have you here. We've been talking to Barbara for a few moments about the educational program Khamp, which has really done a remarkable job of scaling up HCV treatment capacity in Kentucky through training primary care physicians. And I really wanted to get your view, because you've been so involved so much in HIV and hepatitis C testing and linkage to care. What has been your involvement in Khamp, and what's your estimations of it?
Okay. Well, I'm delighted to be here, John, and happy to respond. So here's my involvement in Khamp. I was aware of the program and became more and more aware of the details in the same time period that WVU was starting a Hep C Echo, for which I'm one of the members of the hub. And I think Echo is a great educational and peer educational system, but my concern was that Hep C Echo wasn't reaching enough primary care providers. Since West Virginia has ranked first or second in the United States for rates of acute Hep C over the last 8-10 years, we have an enormous proportional burden in a state that has got a small population, a big land area, a lot of poverty, really limited access to care, and very little public transportation outside of a few cities. So there's just no way we were ever going to get enough people trained through the ecosystem, which is wonderful, but because the didactics are spread out over a long period of time, 15 minutes out of an hour, it takes a long time for people to get started. And then I became aware of Khamp, a lot of connections in Kentucky, and it's the neighboring state, and it's the same patient population, and realized that I could combine what I liked from Khamp, which was the structured didactics where people learn a lot right up front, and then they get supported by a full day of training, and then about 6 months later, an additional half day of training. I could combine that with the Echo format. And so I did that, and I developed something called WV-HAMP, which is the West Virginia Hepatitis Academic Mentoring Partnership, which is a mouthful. And we have worked very, very closely with the Kentucky Rural Health Association, which is the organization that is the home and really the facilitator of Khamp. And we've worked very closely with them. Tina McCormick's the executive director, to set our program up. But it does differ from Khamp in that, in addition to the 8 hours of didactics and 4 hours 6 months later, we have evening webinars monthly that are like Hep C Echo format, where we discuss cases, participants present cases, and then there's usually a short didactic space where we talk about topics that have come up in these cases, or topics that the participants have said are important to them. So we're trying to do the best of both worlds. It is, of course, twice as much work as either system alone. But it's really doing very well. And together with Khamp, we have realized that there are other states that are interested in this kind of approach. And so we've had inquiries from Puerto Rico and Michigan and I believe Tennessee. And Tina McCormick has really set up something called US HAMP, where we hope we will share the didactics and share the system with other state organizations. Now, the one thing that West Virginia really contributed to the overall system was we developed a database in REDCap which of course is HIPAA compliant and facilitates multiple site data entry from everywhere, because Khamp does it by secure fax, and that's what we originally did. And then COVID hit, and no one was going into the office to return a fax, and the system became very cumbersome. And then I wanted to have a database from the beginning, and then I realized, well, wait, we're going to have faxes, and then we're going to separately enter this in REDCap? No, that didn't make sense. So we really set it up so that the primary care providers who are doing the work can enter it. And the other wrinkle that we added to the Khamp system was they weren't collecting follow-up. And West Virginia Medicaid, which is less well-resourced than Kentucky Medicaid, really needed to know, are we really achieving SVR12s in these individuals? Because they're the primary insurer of this patient population. So we have a follow-up form too. So we have 72, first training was March 5th. We have 72 completed consults. The SVRs started rolling in the very end of August and September. We have one provider who has treated 39 people all by herself.
Wow.
She also runs the MAT program at her FQHC. So, she's arch example of co-locating hepatitis C care and addiction services care. And every SVR12 has been a cure. So we're thrilled. And we just spent all day today training another 40-something people.
That's fantastic. And is Medicaid thrilled as well? Are they getting that feedback that this is having an impact?
I am in the midst of setting up a meeting with Medicaid so that we can show them the REDCap database, that we already have a number of maybe 8 or 10 already pre-programmed reports by zip code, by patient, by regimen, by treater, by gender, by sex, and this and that. But we also want to deliver to Medicaid and also to the public health people in West Virginia, the Bureau for Public Health. We want to be able to deliver to them the data they need to for us to really work on an elimination plan.
Yeah, absolutely.
Yeah, so we're about to present the completed REDCap database to to our colleagues in the state and see what they want back out of it. But clearly, gathering the SVR12 data, the outcome data, was crucial.
Well, Barbara mentioned how your REDCap database was a big asset for their program, that they're using it now.
Yes.
In Kentucky.
Yeah, they had a training yesterday and they introduced REDCap to their new trainees. So, and we did it today. So we're hoping, and I think what's wonderful about it is we're really gonna, I think, at least for West Virginia, there are more people who are gonna treat Hep C who are part of this program than any other single program. So we're really gonna have a terrific registry. And we'll have a registry we're back entering Kentucky's first 1,000 cases. And, we will have a registry for, other states and that join us. We will be creating a registry that covers all of the, the partner states. And I think that will be extremely powerful for, at both a state level, everybody has to create a hepatitis elimination plan. But also, as a combined database, that's going to be really powerful and really, I'm very excited about it.
So do you, I wanted to ask you about Khamp. I mean, obviously it's being used in a rural area in West Virginia, it's being used in a rural area in Kentucky, but yeah, I think it has applications for non-rural areas as well. Do you agree?
Absolutely. I think, really, rural areas are just under-resourced for even primary care.
Right. People are more isolated in their practice, et cetera.
Right. But the population of people who have hepatitis C in this country many of whom live in suburban and urban areas, also have access problems. And so I think training, training internists, training generalists, we trained addiction psychiatrists today. I think training a range of providers to do this will be helpful. I at all don't think it's limited to rural areas, but what's so compelling about being in Kentucky and West Virginia is they are so rural.
Sure.
Distances are big, and there's no good way to get from A to B. So,
so this national, you're putting together these tools so it can be used more nationally. Have those already been brought together in some type of website, or is this still in a more of a conceptual, formative phase?
We're working on putting that together. So at the moment, it's a project that's in development, but we have had interest expressed by, as I said, a couple of other states. I think it's primarily through this network of rural health associations. I don't know what we'll do when people are interested, and it's a state with cities of millions of people, but you do need a home organization that has a website, and or at least that's how we've done it here. And the Kentucky and West Virginia Rural Health Associations each maintain a website for the statewide program. I suppose we could have a US-wide website once we had the momentum and the size and the need, but we also need funding. So,
right.
To expand to that level. Right now, this is very largely a labor of love, but I think, the evidence will be there of the value of this.
Absolutely. I'm sure we could develop an economic model that would show it's highly cost effective.
Right. Well, I think, the first order of business is these are not largely internists, these are largely family practitioners, family docs, NPs, and PAs. And, if their success rate in helping their patients achieve SVR is the same in all the published studies that were done by people who are experts in viral hepatitis, then I think that, there's the proof. There's the proof that this is utterly doable outside of specialty settings, that states' Medicaids should not limit the prescription and management of hepatitis C drugs to people who are not GI docs or ID docs or hepatologists.
Mm-hmm.
And I think it will be at an enormous cost saving. The vast majority of the people who've been trained through us all work at FQHCs.
I wonder, it's one of my last question, but it brings to mind as the providers become more confident in treatment, do you think they become better testers? Do you think they do more screening?
Well, you know what? A big part of the educational process for both Khamp and West Virginia Hamp is we lean very heavily on screening. We iterate and reiterate the Preventive Services Task Force recommendations, the CDC recommendations. I mean, you're not going to be able to treat anybody you don't diagnose, and you're not diagnosing anybody unless you screen. And I go around West Virginia giving talks saying everybody in West Virginia, without any identified risks, should be screened for Hep B, Hep C, and HIV, because we have those problems. And, I think risk-based testing is a thing of the past, frankly.
Well, good. Well, hopefully you can continue to scale it up in West Virginia, as they have done so successfully in Kentucky. And it seems like they have, a way forward to remain sustainable for the foreseeable future in Kentucky. And
right. Well, we need, I think, we need a reliable source of funding, which I'm hoping will come from the U.S. Department of Health and Human Services in some format.
I hope so.
This all was both in Kentucky and West Virginia when this was an in-person thing. Kentucky, which has been doing this for like 2 years, and we've been doing it for just since March. The plan was to move around the state physically. So it was easy for people to get to you. They're both, in terms of size and shape, not small places and not easy to get from one end to the other. COVID has upended everything, and it's all, you know, it's all on your laptop now. You know, I think our first training was way south in West Virginia, which is where our opioid epidemic is worst, our overdose death rates highest, and our Hep C rates highest. And we held our first training in this town called Bluefield. There's a Bluefield, West Virginia, and a Bluefield, Virginia,
right
across the border. So very far south. And then we were planned to march around the state just the way they do in Kentucky, move from place to place. But now, I mean, the one advantage to the COVID-induced universe is that, you know, people today who logged on from, you know, Morgantown and the Eastern Panhandle, and, you know, West Virginia's got a funny shape, and there's pieces that stick out and that are actually quite far away from the rest of West Virginia. So, you know, that's the one good thing. The tough thing is getting people to sit in their seats for 8 hours.
sure
That's a bit of a challenge.
yeah
I think I'm just delighted that the people in Kentucky invented this. I think they decided it was people who were in the state health department, and I think they also just decided ECHO wouldn't work quickly enough, because they had that option too. And they, you know, and then they developed this program, and I'm extremely grateful to them, because I don't know that I'd have thought of doing it this way without that example. And I think, you know, I think we have a product and an approach that will work all over. There's just no reason for it not to.
Yeah, no, I think you do too, and I think it's critical to have a local champion, and I think you're it for West Virginia for this.
God knows I'm trying.
Yeah, absolutely. Well, I hopefully you know, we'll continue to talk, see how, you know, I can help you, the coalition can help you as you you know, put your proposals together, because I think it's I mean, you know, the proof is in the numbers. And they have you know, it's worked for Kentucky. It's already starting to work for West Virginia. I think it just needs to be made more widely available now.
And we have, I mean, our star performer is a wonderful gung-ho nurse practitioner who has already in 6 months treated 39 people.
Yeah.
You know, that's an amazing rate.
It is.
You know, if we can keep that going, you know, I'll be really delighted. I have so many people, sadly, that we need to reach. And this is the way to reach them, right? In their communities.
Yeah, you got to. It's the only way, really. Yeah. So
just,
good. Thank you for taking time for us.
My pleasure.
I appreciate it.
All right, I'm taking you up on the assistance. Thank you, John.
Okay. We'll be talking to you again soon.
All right, thank you.
Bye-bye.